somewhat academic.
Why is that sinusitis?
Yeah. Oh, yeah. Gorilla. Yeah, no, pictures are incredible. 450 pounds, silverback. Surgery. I'm sure he has actually published a year here.
Oh, does
I'm
he?
sure I'll bring those same pictures. Dysfunction.
If you're ever not going to be here in the morning, she's going to say, knows how to do it.
Oh.
Yeah. Yeah. It'll be a short session.
I know how.
Okay. Amy, you already.
Yeah.
She's done it before.
Yeah.
As of now, I'm not missing any.
Mike has a tester. He should be able to figure out all these problems.
Yeah. Just plug it into the power supply.
Plug in the power, that's all. Hit on. All this helpful critique, right?
It's a thankless job.
Whenever my clinic comes up with some new computer program that they wonder how fail-safe it is, and they let me try it. And then if I can work it, they say it's ready.
Anybody can do it.
That's right. And if I can't do it, they go, oh, we didn't think of that. And then they go back and fix it. I'm their beta test unit.
What's every clinic use? Epic?
Yeah. Unfortunately, yes, we use Epic. The best of the worst is how it's presented to us.
Mm-hmm.
It's really, I guess, for primary care, it's not so bad. For specialty care, it's just a mess.
All of the EMR programs for specialty care really are pretty crappy.
But they can monitor us from DC without getting on a plane now. That's how the government cares about it. They don't care that we struggle with it. They just want to be able to use it.
That's right.
Is anybody working on making these systems compatible with one another?
No. They can talk to each other through an interface called CCD, but it's still not there yet.
Still faxing records.
There's too much proprietary stuff that they don't talk to each other.
Sorry.
What's interesting is Epic in the hospital can't talk to Epic in the clinic.
That's right.
That's we have to go through a different interface to do that.
Doesn't the university have work
University goes to Epic.
but not all of it.
Inpatient is not.
Yeah, inpatient is working on outpatient.
So somebody comes in who has their problem. You go in there and you can
There's our guy, man. This is on Airway. I know we can see it at the hospital, but it's not easy. But through Pathophysiology, they can get the hospital, they get it.
I'm trying to be real good.
Patient portal, I help patients pull up their chart on their iPhone.
Yeah.
So that's, we just, they just make uptake.
Assistant's what I have. I've done with
You just push it because it's so much easier. When you find somebody who's inactive, you think, all they got to do is log on.
But I have to.
Once they've done that, they find out they can actually work on it.
Yeah, that's one of those.
Well, this is not good. I don't know.
You're ahead of everybody.
We've only been doing the patient portal.
It's fine today. See what happens tomorrow.
It's actually Swedish.
Getting surgery or had surgery?
Tomorrow. I'm not looking forward to the ribs this summer.
Yeah, keep my hands right.
Home skiing across the major is your arm trussed up inside your
Yeah,
department.
you can just get a sling and just stay with the one arm. So, Bill, did you work out all our parking problems yet?
I'm sorry?
Did you work out all our parking problems yet?
Yeah, got Trixie working on that. It's kind of challenging because see the underground is all you need an access card because it's not aerated.
Should we like hire somebody to stand there and just let us in? Let us get out. You don't need a card just to get in.
You need a card to one of these proximity cards. Charge it to you that card. Because they're on
Buses like that. Alright, I must have
Joe will be retiring when you have his car.
And my card, I could be the doorman down there.
There you go.
You could just have one of these construction guys park their big truck under the gate so it couldn't
To keep them up.
Must have had mixed feelings last week.
Oh, that's been here so long. You can't refuse to figure that out.
The word of the day is upper airway.
They are so good at this. Well, luckily somebody got them.
Good morning, everybody. I don't know about the rest of you, but parking is really still starting to become an issue around here. I don't know if there's anything you can do about it, getting us to park under the building.
Popular guy.
Anyway,
We're working on it.
again, so for CME credit, as we said, upper airway is the word of the day. Speaker today, Ron Balkissoon, very kindly came here, probably left better weather, sorry, our winter looks like it started. From Denver, from National Jewish. Very interesting presentation this morning. You can see the title as well as I, Cough, Pathophysiology, Upper Airway Perspective. I looked through the handout yesterday. It's really a very all-encompassing, very interesting presentation. So again, thanks for coming. And you've got a pointer here with the mouse.
Well, good morning, everyone. Thank you so much for waking up early enough and coming out. It really is a pleasure to be here. My name's Ron Balkissoon. I'm a pulmonologist, and I work at National Jewish at the current time as a contract pulmonary consultant. I was on faculty for 17 and a half years, and I was going to leave, but then came back a couple years ago because of some family illness. And what I do now is I actually just do an out-of-state clinic. I used to run the fellows program and a variety of other things. But one of the major groups of patients that I see, so all I do is 2 or 3 weeks of the month, I'll have 6 patients who come from out of state to see me. And every week, at least 1 or 2 of them have chronic cough. And many of them come to see me saying that they've had a chronic cough for 30 years. Which just deflates me because I think, you think I'm going to be able to change this in 4 days. But, so cough actually constitutes up to 40% of outpatient visits for pulmonary medicine. We spend somewhere in the order of $3.2 billion a year in over-the-counter medications to treat chronic cough in the U.S., 90 million pounds in the UK. And so it certainly is not only the bane of pulmonologist but also for an allergist, I'm sure, with all the issues of upper airway congestion and allergies. And so I know that you're all aware of that, and I know that you all probably deal with this. So I'm not going to go over any of the sort of basic issues about chronic cough. What I did want to try and discuss and deal with is those patients who have recalcitrant cough. So we all recognize that a lot of it can be solved. Probably the number one issue is upper airway cough syndrome and/or postnasal drainage, and certainly that's something that as allergists you're very attuned to treating. But we treat patients with stuff for that. We treat patients for reflux. We treat them for eosinophilic bronchitis, and yet there's a group who remain recalcitrant to therapy. So what I'd like to talk a little bit about is that group and how is it that they get there? And ultimately then, what is it that we do to try to deal with their difficult to control condition? These are just some of my conflict of interest that I'll put up. I'm not really going to be talking about any medicines today. And, I'm not sponsored by anyone to give this talk this morning, but I know that AstraZeneca is providing you with references. So the thing that I think you can appreciate from this review and summary of several studies that try to look at the etiology cough is if you look at the groups, and this is an older paper because you can see they're using the term postnasal drainage as opposed to upper airway cough syndrome. But postnasal drainage, bronchial asthma, and reflux really account for the major proportion of chronic cough. And certainly the cough guidelines that came out from the American College of Chest Physicians in 2006 emphasized empiric treatment. You take a history, do they have symptoms that are suggestive of reflux or postnasal drip? You treat them for those types of things, and you see if they get better. It's not that you necessarily have to do a host of investigations, but if they don't get better on the basis of treating those major causes, then one starts to look at using a variety of different investigations, including sputum, if you can collect it to make the diagnosis of eosinophilic bronchitis, which has kind of moved up in stature as far as a major cause for chronic cough as well. And then, CTs, methicillin challenge, other things to try and tease out what might be other causes for chronic cough, interstitial lung disease, etc. So, but by and large, the major causes, as you can see, really constitute those major things. And most of the time, if we try to treat those, we can get things under control. This is actually interesting. This is just a paper published last year from China. And this is an international problem. In the last 10 years, there's been about 6 or 7 major international guidelines on chronic cough to describe how significant it is. So this was a study from China, and it basically shows that even in China, the major things are all the same in terms of bronchial asthma, upper airway cough syndrome, eosinophilic bronchitis, etc. So it's pretty universal as far as these being the major types of issues. It's interesting that they had this designation of atopic cough as a cause to distinguish it from things like upper airway cough syndrome. So that's kind of interesting. And their reflux rate was a little bit lower than it's been reported in other areas, but otherwise pretty much the same. So when we think about the causes of chronic cough, certainly in the upper airway, ongoing sinonasal disease and post-surgical failures and phenomena represent significant things. So think about fungal disease. We see a lot of people who have allergic fungal sinusitis, which can be something that needs to be dealt with. A lot of the people that I see who have upper airway issues have chronic bacterial overgrowth. A lot of them have persistent Staph aureus in the upper airway, and there's whole literature about that acting as a superantigen and increasing their allergy response as well. So that's certainly something that we'll come back to talk about in a little bit. There are, this is always an interesting phenomena. I have to admit, I've never seen it, but some of my colleagues swear that they've seen individuals who have irritation of the external auditory canal with the air in the ear being a cause for chronic cough. Richard Martin always likes to give the story of finding that and someone removing it and their cough magically going away after having it for 15 years. And then there's direct contact irritation. So post-nasal drainage, as we talked about. But I think one of the things that we all understand why we moved from talking about post-nasal drip to upper airway cough syndrome is that it's not just the mechanical irritation of post-nasal drainage hitting the back of the throat that increases laryngeal sensitivity and causes cough, but rather, probably more importantly, we really now talk about the upper and lower airway being a unified airway, and that there's a significant amount of crosstalk. So there's been studies that have been done where they put allergen, and I know you're all familiar with this, where they put allergen in the nose, and people have a negative methicillin challenge, and they've taken biopsies of the upper airway and lower airway before and after allergen challenge and been able to find inflammatory changes occurring in the lower airways, even in the absence of not having a positive methicillin. So there is this, if you have the upper airway irritated and inflamed, it causes lower airway increased sensitivity and responsiveness as well. Interestingly, there were some studies that I recently reviewed where they showed that individuals who had chronic allergic rhinosinusitis, if you looked at the methylcholine PC20FEV1, it fell in the normal range. But if you looked at the PC40 SGAW, which is a measure of airway conductance, which may reflect more smaller airways, that came back as positive. So I think more and more we understand that it's not just about the mechanical irritation of postnasal drainage hitting the larynx and vocal cords and triggering cough, but rather when a person has an inflamed upper airway, it really does trigger the lower airways and make them more sensitive. Not only the lower airways, but also the larynx. So there's just some CT images outlining ongoing upper airway disease. And when you talk about the cough reflex, it's important to appreciate that the cough reflex is really a protective reflex. It's a natural reflex that is geared to keeping everything out of the lungs that shouldn't be there, which is everything except nice, clean air. So if people have stuff that's coming up into the larynx, stuff that's draining from the nose, even stuff in the lower esophagus, is capable of triggering a cough response. So there are these sensory nerve receptors, these afferent receptors, that are located throughout the sinuses, the upper airway, the larynx, even in the heart, the lower esophagus, which all act as guards to identify whether or not there's any potential threat to the airway. So these sensory nerve receptors all end up going through the afferent limb of the superior laryngeal nerve. There's cortical processing. You know that we use opioids to try to suppress cough, so there's a central modulation of the cough response. And then you have the afferent response to the recurrent laryngeal. This is just defining the different components of the airway. And this is what I was just talking about before, that we really think of the larynx as a gateway and gatekeeper to the lungs, and therefore it makes perfect sense that this area will be protective and responsive to a number of irritant stimuli. And again, I know I'm preaching to the converted, but when I speak to others, I really try to emphasize the central role of the nose, that it serves a variety of different functions of heating, ventilation, and air conditioning, because the lungs just expect to find nice, clean, humidified, temperature-regulated air. And it's why the nose works overtime in trying to modify and make sure that the air is appropriate for the lungs to deal with. This is just showing you, pardon me, this is just showing you the variety of sites where one can find these afferent cough receptors, and I've talked about this already. And there are these different types of cough receptors. There are myelinated, rapidly adapting irritant receptors, and the non-myelinated, slowly adapting C fibers. And then in terms of afferent nerves, I've listed them right there, the trigeminal, glossopharyngeal, superior laryngeal, etc. There are a variety of different stimuli that are known to trigger these different types of receptors, the chemoreceptors. You can see that you have this list here. And then mechanoreceptors that respond to pressure, flow, proprioception, and drive that can be stimulated by laryngeal muscle contraction. The irritant receptors are nociceptive C fibers, and there are these G protein coupled receptors. And then the transient receptor potential vanilloid and ankyrin. These are very important targets, which actually there's a lot of research right now on trying to find blockers that will help in terms of cough response and cough hypersensitivity, and trying to block these TRPV and TRPA receptors. I'll come back to that in a little bit. The TRPV1 give a burning sensation, and TRPA give burning cool sensation, and then these C fiber neurons often give a sensation of itch. And I actually ask patients, so I ask them to point to me, where's your cough triggered? Is it, a lot point to the throat. Some report point to the central chest, and I ask them, is it an itchy sensation? Is it a pain? What is the type of sensation that seems to be the thing that triggers your cough? And I think that can be helpful. So this is just showing basically the activation of these nociceptive fibers. So bradykinin can be released obviously from allergen and a variety of other things attached to these coupled proteins, which help in activating these receptors, which really are just channels, ion channels in the membrane. At the end of the day, if you have the appropriate significant amount of stimulation, you're going to cause an action potential, which then can lead to the transmission of this to the nerve, to the brain for central processing, and lead to a cough. So here are a couple of things that I think are interesting. So this is a study that was done with the recognition that there are certain patients, children for instance, who can develop laryngospasm when they're given halothane as a topical anesthetic. And it's thought that this is through activation and stimulation of laryngeal C fibers. And it's important to appreciate that about 50% of the afferents in the superior laryngeal nerve are these non-myelinated fibers. So what they did, they took a guinea pig model where they isolated out these laryngeal mucosa C fibers. They exposed them to halothane. And then what they did was they did a capsaicin challenge to see whether or not there was an increased sensitivity. In other words, it took less capsaicin to trigger an action potential. And what they found was that after this halothane exposure, it increased the sensitivity to these, of these neurons. So you can upregulate and increase sensitivity by exposure to a variety of different things, and we'll come back to that in a little bit. This just shows the relationship between capsaicin exposure in individuals who have asthma and COPD, and you can see that their airways are much more sensitive to capsaicin than normal individuals. I was just relating a story last night at a talk I gave about a football player who had fairly severe asthma and was doing an exercise drill, developed problems with dynamic hyperinflation and severe shortness of breath. They said they thought he was hyperventilating. I didn't treat him. I was asked to act as an expert witness. And they gave him a bag to breathe in, and that bag had some capsaicin in it from a heating pad that had been used. Capsaicin is used as an agent of that. This young man died, unfortunately. It's very tragic. This is just, I think, a very interesting paper where Katrina Buca had a group of patients, 106 patients who had chronic rhinosinusitis. And she treated them with antibiotics and inhaled nasal steroids for 2 weeks. And she was trying to look at these two phenomena, bronchial hyperresponsiveness and extrathoracic hyperresponsiveness. So one of the areas I've been interested in is vocal cord dysfunction. And a lot of that is the same issues as there are with chronic cough, about increasing the upper airway hyperresponsiveness. So they did nasal swabs and lavage, measured serum, IgE, and RAS studies. And this is just looking at that forced expiratory flow at 50, FEF 50, and FIF 50. And you can see that normally, for people who have normal lung function and normal spirometry, that the inspiratory flows are greater than the expiratory flows. And so the ratio is typically, if you do the FEF 50 or FIF 50, it's less than 1. But people who have vocal cord dysfunction and develop extrathoracic airway hyperresponsiveness, they develop truncation of that inspiratory, they develop truncation of this inspiratory loop, so it becomes flattened, and therefore the ratio flips. And so that's a way of identifying individuals who might have some degree of extrathoracic airway hyperresponsiveness. And so when they examined these patients, they found that there were about 86% of them who had extrathoracic airway hyperresponsiveness, and about 52% who had both extrathoracic and bronchial hyperresponsiveness. And when they did nasal lavage, they found high numbers who had significant neutrophils, and about half of them had significant eosinophils. And when I do nasal lavage in all my patients, whether they have asthma, chronic cough, and we will find significant numbers of them who have persistent, significant neutrophils in their lavage, even if they have environmental atopy. Neutrophils are often significantly present. This is a busy chart, but at the end of the day, what they were able to show between before and after treatment, if we look at no major changes in the FEV1, but you do see changes in the PC20. You see changes in bronchial hyperresponsiveness in terms of the numbers going down. You met the criteria for having bronchial hyperresponsiveness. And you also see a significant drop in the numbers who had evidence of extrathoracic airway hyperresponsiveness. So again, I think coming back to that, the new notion of talking about upper airway cough syndrome, that if you relieve or reduce the amount of inflammation in the upper airway, you decrease the sensitivity and the laryngeal responsiveness. Now, this is one of the areas near and dear to my heart, and the whole notion of reflux disease and its role in asthma exacerbations, chronic cough, vocal cord dysfunction, I think is a really important area that I think there's so much that can still be done in terms of understanding exactly what happens. no question that when individuals have acid infused into the lower esophagus, it actually can cause bronchoconstriction. And we understand that there are shared neurologic pathways that can lead to that neuropathic or neurologic type of bronchoconstriction that occurs just from acid being infused into the lower esophagus. So lower esophageal acid exposure triggering cough, that probably can be controlled by use of proton pump inhibitor therapy. But one of the things that's really important to appreciate that there are a number of individuals who are high refluxers, and if they're high refluxers and they have the evidence of developing Laryngopharyngeal reflux, then giving them PPIs doesn't really solve the problem. Because the gastric mucosa and the esophageal mucosa, it's a squamous epithelium, it's made to deal with chronic acid exposure. But the lower laryngeal area, and certainly the trachea and the bronchi, have a totally different epithelium. And if you have even non-acid reflux reaching the upper airway, it's capable of increasing the sensitivity of those areas. And that's why I take issue even with that large New England Journal study that was looking at patients who had positive ethylcholine but had silent reflux, a positive pH probe, and then they gave them omeprazole for many months and they didn't see any improvement in their acid control. Well, if their problems are more upper airway or upper esophageal and laryngeal non-acid exposure, then treating with proton pump inhibitor therapy doesn't really approach or deal with their issue. From the asthma point of view, a lot of what I do in the people who have severe asthma is we do bronchoscopy on them. We do impedance probes, and we'll find that, and many of them have chronic cough and or vocal cord dysfunction, and we'll find that when we take bronchial biopsies, we'll find that they have squamous metaplasia in the lower airways. And there's papers that have shown that people who are aspirating will actually develop this transformation of the epithelium. So reflux disease is an area that I think plays a significant role in chronic cough. I talked here about these vagus afferents that can stimulate cough even by acid infusion in the lower esophagus, and then there are these supraglottic issues that I've just talked about. The things that you can find for individuals who have laryngopharyngeal reflux is highly subjective. There's a lot of debate about what really constitutes significant changes to be called LPR. A few of my colleagues at National Jewish, Jim Good, Richard Martin, have come up with this index that they try to use, this supraglottic index, which I think can be helpful in some ways, but none of it really, I think, is definitive. I think it takes clinical judgment at the end of the day. But these are the different items that may be present. You have this edema and erythema of the supraglottic area. There are epiglottic malformations, posterior pharyngeal wall effects that you can see. Lingular tonsillar hypertrophy can be also noted. And these are just some of the findings that you can see in terms of edema of the epiglottic folds. You get this pachyderma or thickening of the posterior commissure. And I think studies that have been done in the ENT literature suggest that one of the things that has the highest association of LPR is seeing this posterior pharyngeal cobblestoning. Whoops. This posterior pharyngeal cobblestoning right here. And here I have a photograph of a patient of mine where you can see the thickening and epiglottic fold edema, the posterior commissure thickening as well, and then you can see this cobblestoning in the posterior pharynx. And this is, I think, a good example of the laryngopharyngeal reflux. And studies that have, we don't do this routinely, but studies that have actually biopsied laryngeal tissue can find these squamous changes in the laryngeal tissue, which again is consistent with the laryngopharyngeal reflux. And I don't think you need to biopsy every patient to confirm that as being present. And these are the same kind of changes that I was referring to that we find when we look in the lower airways when we take endobronchial biopsies. So before they had impedance probes, what I used to do in patients like this, whether they had asthma, recalcitrant asthma, or they had chronic cough, was when we did our pH probes, we would just have a simple distal and proximal probe, and we would be measuring how many times they had excursions of the pH below 4, and those were the things that were typically recorded in the readout for the Johnson-Denister score. So what I started doing was actually drawing a line at 6, because there's literature that suggests that you can get laryngeal damage even if the reflux state has a pH of 6 or less rather than 4. And so then when you do that, I'm sorry about this, but when you do that and you draw a line across here, I think you can appreciate that there are a lot more positive events than if you just use a pH of 4. Now, of course, we have impedance probe monitors, which are very helpful in identifying the non-acid events and acid events. And while I appreciate the fact that the impedance probe is really set up to look at, are there enough esophageal events of acid exposure that can cause esophageal reflux esophagitis? The way that we use them as pulmonologists is really qualitative, to look at how frequently are they having proximal non-acid events versus acid events, and what's the correlation between those proximal events and episodes of either chest pain, throat irritation, coughing, a number of the things that are often associated with chronic cough. So those are the kind of readouts. And so you get a sense, the nice thing with the impedance probes, as you all know, is you get a sense of both retrograde and antegrade flow, so you can tell what direction things are going in. I think this is an interesting point. So this was a study that was done where they actually had a cough monitor, so that they had a way of recording cough events and temporally relating them to the reflux events. And what they were able to show was that about 15% of the time you had a cough causing a reflux event, 15% of the time you had a reflux event and then a cough, and about 70% of the time there was no correlation. And so in the cough guidelines, they've said that you can't try to look at using impedance probe correlation with cough to make decisions about whether or not reflux is causing the cough. And I agree with that, because when people have chronic cough, I've just talked about this upper airway cough syndrome, increased laryngeal sensitivity, that once they have that increased laryngeal sensitivity, there are going to be a whole host of exposures that they have and events that they have that are going to cause a cough that are not going to have any relationship to reflux. And so just because there isn't a close, tight correlation to all their cough events and reflux events doesn't mean that reflux isn't part of what's contributing to their cough. But I will say this, and I wish I had the video as part of this presentation, is that we've done some studies on our patients who we suspect this as being an issue, that during a barium esophagram, obviously people are tilted up and down, but they're not typically asked to cough. And it was just by serendipity that once one of our patients coughed while they were doing their barium esophagram, and we just saw this column of barium just shoot up into their throat. And so I think that one needs to appreciate that cough actually causes a certain amount of reflux. And these may be events that don't cause heartburn or indigestion. It's like these microboluses of material that will shoot up into the larynx and then contribute to increasing laryngeal sensitivity, which then can lead to a number of cough events that aren't tightly correlated with reflux. And so I think that reflux continues. The cough begets reflux events that then begets the cough, and is part of the vicious cycle that we see. This is just making reference to the study. Oh, it got cut out there. But essentially what they did was they found an individual with chronic cough. They did bronchoscopy. This is one of the things that led to us doing our investigations. And what they found was they found that the individual actually had significant squamous metaplasia of the endobronchial epithelium. So with reflux disease, I actually think that, yeah, there are some people, if you have significant lower esophageal acid reflux, that's enough of causing cough. And those people, treating with PPIs probably does solve the problem. But for those individuals where the cough is actually contributing to the reflux events, then PPIs aren't going to necessarily solve that issue. The next area is talking about nasopharyngeal reflux. Just very quickly, a lot of people, when you do rhinolaryngoscopy, what you'll find, and they've been on chronic nasal steroids, you'll find that the anterior nares look pretty good. But if you go to the very back, you often see this type of cobblestoning that is not dissimilar from what you find in the lower pharynx. And so there's been a lot of interest in whether or not individuals who have reflux disease might have actually some degree of nasopharyngeal reflux. And you're probably familiar with this literature that's looked at what the relationship is between individuals having nasopharyngeal and laryngeal reflux and postnasal drip symptomatology. And so what they did was they actually had a probe that measured the degree of nasopharyngeal reflux, and were able to show good correlations especially when they looked at events where the pH was less than 5 rather than less than 4. Less than 4 was too stringent a criteria, but when you include events where it's less than 5, there's a very nice correlation between finding evidence of nasopharyngeal reflux and these measures, these questionnaires that are correlated with the degree of upper airway congestion and postnasal drip that they have. So that seemed to be pretty compelling. And what I thought was interesting, pardon me, is that you can see the effects of doing nasoendoscopic surgery and then being able to look at this nasopharyngeal reflux and finding that many of the individuals do indeed have significant symptoms of nasopharyngeal reflux. This is one of the things that I really found interesting, is where they did nasal lavage and they measured pepsinogen, and they found that in a high number of the patients who had ongoing problems with chronic rhinosinusitis, that they could identify pepsinogen in the nasal lavage, and these were people who had otitis media with effusions, middle ear effusions. And so I think that there's compelling evidence that it actually can occur and may be contributing to their postnasal drainage. It may be an explanation for even the people that we see who have significant environmental atopy. When we do nasal lavage and we look at their cell counts and differentials, we look for nasal eosinophils, that a lot of these patients have more neutrophils than they actually have eosinophils in the upper airway. ACE inhibitor, yes, please go ahead.
Our ENT surgeons are using a nasopharyngeal pH probe and saying that that picks up reflux that the distal esophageal probes do not. Do you find that that's actually true?
Yeah, I think that they're a bit problematic. There's a lot of noise with them, but I think in experienced hands, they can make a reasonable interpretation of that. And so, yeah, there are these nasopharyngeal probes now that can pick it up. Do I think it's essential in making the diagnosis? Probably not, but I concur, and actually one of the papers that I showed here used that kind of a probe. So I do think that it can be useful.
And can you have acid in the posterior pharynx without acid in the lower esophageal sphincter?
Well, I think that what happens is every time you have these types of cough events, my analogy that I give people is, especially with patients, is you can think about the stomach and the esophagus like a turkey baster. That what happens is that when an individual has nasopharyngeal reflux, every cough event causes a brief bolus of stuff that's very transient and just shoots up through the esophagus, doesn't really have much resident time in the esophagus, but then gets up into the sinuses and can actually sit in the sinuses, because when when a person's upright, they may not have as many events, but when they go to bed at night and you turn that over and you squeeze it, it's going to go right out the top, and then it can sit up in the sinuses and be resident there. So you can certainly find it there because it'll reside in the sinuses and not necessarily see evidence in the lower esophagus. Again, point being that the lower esophagus has an epithelium that's very easy. It can handle transient small amounts of acid. You're not going to see much damage, but the upper airway isn't really accustomed to that, and so if it remains resident in the sinuses for a period of time, that's how you find it there, and you don't find it in the lower esophagus. If the consequences of even a small amount of acid in the upper airways and the lower airways is much greater than it would be in the esophagus. Okay. ACE inhibitor cough, I'm not going to say a whole lot about it. Obviously, it's found that ACE inhibitors can increase the breakdown potentially of bradykinin and substance P, and as a result, those remain present in the airways and may increase cough sensitivity as a result of that, and that's typically what's thought to be the mechanism of that, and these people will have increased capsaicin sensitivity as well. There seems to be a subgroup, middle-aged females, who seem to be particularly susceptible to ACE inhibitor-related cough. And so, obviously, that's something that one needs to be aware of, and stopping it and seeing if it goes away after it can take up to 2 months to see that response. So one should keep them off of it for at least that amount of time. There seems to be less with the angiotensin receptor blockers, although there have been some reports that they can also cause some degree of cough, but nowhere near as much as you find with the ACE inhibitors. All right, this is just an area that I did a lot of work in occupational asthma before I moved into the general pulmonary condition, because I started off in the, I just want to see how we're doing with time. Okay. I started off in the occupational lung disease group, So an area that I've always been interested in is occupational asthma. And one of the subgroups that I was asked to see a lot were people with reactive airways dysfunction syndrome or irritant induced asthma. And so a number of people would come with these histories of intense exposure to ammonia, and chlorine, dust, and be deemed to have reactive airways dysfunction syndrome. And amazingly, a very small number of them had even had a methylcholine challenge, which is one of the criteria, a positive methylcholine challenge to make the diagnosis of RADS. It's just presumed that they had reactive airways dysfunction syndrome. And so when we evaluated these people, what we actually found was that a high number of them had evidence for vocal cord dysfunction. We would do laryngoscopy following our methylcholine challenge, or I would even do I developed this exposure chamber at National Church, so we could actually do blind irritant exposures versus sensitizer exposures to try to tease things out. And we would be able to elicit their symptoms, and we would indeed find that most of their problem was vocal cord dysfunction rather than asthma. And so I bring this up because there's a lot of overlap between people who have vocal cord dysfunction and chronic cough, because they're both about increased laryngeal sensitivity. So these were the criteria. Basically, they had no prior history of VCD or laryngeal disease prior to their irritant exposure. We confirmed VCD with laryngoscopy, and we compared 11 cases with 33 matched controls. And these were the things that they were exposed to. These were the backgrounds, but there's no significant difference between it's a very small group, obviously, but between our cohort and our controls in terms of their backgrounds. One of the things that had been looked at previously were healthcare workers, psychiatric history as being predispositions to developing vocal cord dysfunction. We didn't see any of that type of association. One of the things that we did find was that a lot of them reported problems with chest pain, which was more common in our irritant VCD patients than it was in the controls. And I think, obviously, we worried about how much of that was related to reflux, but there's definitely also this increased sensitivity of the lower airways in a number of these people who have reflux or have had significant irritant exposures. They can increase the tracheal sensitivity.
Are these the kind of people who have one large toxic exposure
Yes.
from a mistake, not those who
Not the
chronically
RADS
exposed?
type, the lower. It's this significant, sentinel event where they had very high level of exposure after which they've had persistent problems. But some of them had histories of a sentinel event, but also had ongoing exposure to relatively low levels that before the event they seemed to be able to tolerate, but after it they found intolerable. So at the end of the day, when we looked at these individuals, and found this type of association, I then went back and reviewed all the patients that I had had up to a certain period of time who had been seen who had problems with VCD that, and also came in with a presumptive diagnosis of RADS. And what we found when we looked at those after we had done the appropriate testing, methylcholine challenge, laryngoscopy, that we had a group who had VCD alone, which was about 12 of them, and then there was a group who had VCD and RADS, which in the literature is not unlike what you find between VCD and asthma. That VCD in isolation certainly occurs, but there are a number of people who have VCD and also have asthma. And we found that same sort of phenomena in this cohort. And what I was going to say is that when you look at things that predispose them, you can see the high proportions that had reflux and also had postnasal drainage, so 91% and 66%. In those who had VCD alone, and those who had both of them, you can see what the relative proportions were there as well. So I think that these are often the things that increase that laryngeal sensitivity from a variety of different mechanisms now that I've tried to explain. So when people come to me with a history of chronic cough for 25 years, and being evaluated for all these different things and being put on treatment for all these different things, but are still not doing well, I still don't discount these issues as being the things that continue to contribute to their chronic cough. One of the caveats to the cough guidelines is that they mention empiric treatment, sequential empiric treatment of these different things. And then they kind of mention, and I don't think they emphasize enough, that what you really need to do is identify all these players and treat them all very aggressively at the same time. Because if you only try to deal with the reflux alone, if you only try to deal with the postnasal drainage, and if you only try to deal with the habituation component or the neuropathic component by giving them central cough suppressants, you're only dealing with one issue. And unless you deal with all of these different components, people's cough will persist. And people need to understand that for the Laryngopharyngeal reflux side of things, just treating with proton pump inhibitor therapy does not suffice. And it's not unlike the chronic, sort of chronic pain situation when you talk about neuropathic cough. So I'm sure you're familiar with the recent literature that has been able to show that bronchoconstriction itself, either from a methacholine challenge or allergen challenge, when they've done bronchoscopy before and after, they've shown airway remodeling changes just as a result of the bronchoconstriction itself. So what's really, I think, important for us to understand is that the more people cough, the more they irritate the larynx, the more they cause some irritation of the lower airways, and that stimulates and causes inflammatory changes in and of itself, which will persist and increase the airway sensitivity. And so it really has sort of fallen along the whole notion of this neuroplasticity, and that over time you lower the threshold that triggers the cough by having the chronic cough itself and these various other types of stimuli. So, talking about management now. So we're postnasal drainage. I'm just very quickly going to go through a few things. One of the things that we found is that a lot of these people have chronic, evidence of chronic staph in their nasal passages, and so we'll do such things as use new Pearson rinses. Do you do those very often here? Or? Yeah. And so this paper really is very supportive that this can be helpful in dealing with people who have recalcitrant or chronic rhinosinusitis. So we find those helpful, and I'm sure that you also use nasal steroid rinses sometimes when topical nasal sprays themselves don't seem to help.
Are there controlled studies to show that?
Mm-hmm.
That one wasn't, though.
Yeah. There have been, yes, you're right. And there have been a couple of control studies. I unfortunately haven't included them in. But if you go to the ENT...
Those are the important ones to have, not the anecdotal
You're absolutely,
ones.
you're absolutely
You know, I'm a
right.
skeptic about that.
Yeah.
How do you quantitate that bacteria?
Skeptic about everything.
Yeah. Well, I need data. I need double-blind placebo control. It's like acid reflux. If you look at the data, the studies show a lack of response to PPIs. And so all the doctors are making diagnosis of chronic cough, and they believe it causes, but the studies don't support it.
So yeah, and I think that part of the issue there, as I was coming back, I think has been about study design, and that PPIs are not and I'm going to come to that PPIs do not solve the issues of reflux in chronic cough, because all they really are geared to is suppressing acid. And when you're talking about upper airway reflux and or aspiration, even non-acid refluxate will cause a problem. So I do not think PPIs are useful in that regard. And you're absolutely right. I need to put up some of the control studies in the ENT literature that have supported.
I just wonder, how are they quantitating this staph overgrowth? You know, are they just culturing the nose, or what?
Yeah, they're just culturing the nose. It's not even quantitative. It's more or less, I think that it can be multifactorial, but especially in these people with chronic cough have a number of things that are contributing to their chronic cough, only one of which may be this certain amount of chronic staph colonization. Maybe the nasopharyngeal reflux is creating the milieu that leads to this chronic colonization. And so I think the major problem, or the major challenge, let me put it that way, in dealing with things like chronic cough is that if you were to just do this in isolation, you are not going to take away a person's cough. It's just, but if you don't deal with all the factors all at once, you're not really going to be able to show a significant signal from just trying to deal with one single issue. But, so I agree with you. This is probably not the best study that really...
I can believe this one, quite frankly, because of the fact that you say that they have a chronic sinus disease. But how about all our other patients that cough that really don't have any evidence of sinus disease? Do you think that staph overgrowth plays any role in them?
I think if you look at their nasal lavage and they have a ton of neutrophils in it, and you look at their nose and it looks to be chronically inflamed, And if from the rest of your history you have compelling evidence to suggest that they have nasopharyngeal reflux, I think that creates a reasonable, plausible clinical grounds to think that it may be a contributing factor. And my point being is that if I even tried to do a study where I just looked at that in isolation, I don't think that their cough would go away. But I do think that it's part of the scenario that creates the environment where people have 25 years of chronic cough. I just had a guy who had gone through the gamut, had 25 years of chronic cough, took this approach from multiple different angles, and for the first time in 25 years, his cough has gone away. And he's been tried on central suppressants, he's been tried on PPIs, but not everything has been dealt with all at the same time.
You're going to tell us what that approach is?
Yeah.
That's right, you have to come to National Jewish to find out.
While we stopped you in your tracks, you talked about the people with vocal cord dysfunction in isolation and having a high correlation with reflux. And what about the people with VCD who get better with speech therapy and they get better with no treatment of any acid at all? Do you think that still correlates to those people?
No, not necessarily. I think that there are people who have VCD alone where it can have more of a, the classic description from colleagues at National Jewish early on was a bunch of nurses, a history of abuse, and certain underlying predispositions to depression, anxiety, etc. And in that group, I think speech therapy is incredibly effective alone. But there is a larger number of individuals who we see who have a component of vocal cord dysfunction where reflux and postnasal drip and all these other things are contributing to it.
So they're two separate groups.
Yeah, I think the group who speech therapy alone works in are the group who is really more psychogenic, and I think that but there's a larger number who have some component of vocal cord dysfunction that's really being driven by some of the same things that make their asthma more difficult to control if they have chronic cough.
True, you and Steve had a paper on a very big cohort, right?
Not a lot of them had GERD. Actually, the highest percentage had allergic sensitization. It's a very different patient population. It's young, healthy females, soccer practice, winded. So there are different, I think, phenotypes in BCD, and I think I agree with that. But in that group, actually, the speech therapy is very effective. But there's not a lot of good studies that I'm aware of proving that point.
No, but that's a group where you could see that speech therapy may be very effective because presumably, hopefully not many of them have reflux. But in the older population, and this is what I want to say, is that looking at a readout from an impedance probe and whether or not it says that there's significant reflux doesn't help in addressing this issue because all the values that are set up in an assessment of impedance or pH probes are really asking the question, is there enough acid reflux to cause reflux esophagitis? And that's a much higher criteria than it is to have some proximal reflux getting into the throat that may be acid or non-acid. I showed you a study there earlier that showed when you lower the threshold, in other words, when you went from a pH of less than 4 to a pH of less than 5, I even look at, because of research that suggested even pH less than 6, and you look at the number of events, they're much greater, and there's a much greater correlation because those types of events can cause problems for individuals who have upper airway issues. And so trying to look at whether or not the pH probe reading is positive or negative isn't as helpful from my point of view as looking at it qualitatively to see how often do they have proximal events, what's the correlation between those proximal events and causing some of the symptoms that we're often associating, whether it's throat irritation, chest pain, or actual cough. So I think that that's one of the things that we have to take into account when we're deciding whether or not an impedance probe or a pH probe is positive or negative, how relevant that readout is in terms of what we're trying to address clinically. So that's just the pepsinogen story that I talked about. Okay, so when it comes to the upper airway, when I'm treating these patients, because a lot of the stuff that you see, a lot of them are on topical nasal steroids, and I'm only going to say this, is that I'm currently doing a prospective study trying to look at this, but my approach has been using when I see that significant posterior nasal inflammation, is using oral steroids for 2 to 4 weeks, moving then to using a topical nasal steroid rinse, plus or minus. Not everyone. If I find that they have evidence of staph and they have all these other things from their nasal lavage of lots of neutrophils, then I will use topical antibiotic Upiricin as well in that group, and use that for about a month in terms of trying to deal with that component. And then because of nasopharyngeal reflux, again, trying to deal with that with PPI isn't the answer. It's all the lifestyle measures that are important, because you need to try to reduce the number of proximal reflux events, so raising the head of the bed. All those things are as important or more important than the use of PPIs in that patient population. And then what's also important, because we've shown, and it's been shown, that the cough events themselves can cause that stuff to come up. So for a period of time, I will also put those people on central cough suppressants. So I'll use opioids to just try and suppress the cough. And just as we have speech therapy techniques that are used for VCD, we have speech therapy techniques that are used to break the cycle of chronic cough. So they learn those types of techniques in cough suppression. So those are all a big part of what we do in terms of the nasopharyngeal reflux component of things, and upper airway cough syndrome in terms of that upper airway sensitivity. For reflux disease, you can certainly use things such as like bethanocol and baclofen when you think about the issues that are contributing to the developing reflux. And some people will have a lot of esophageal dysmotility. We actually see people who've had a Nissen fundoplication, which was presumably going to solve their problems with cough, and yet their cough persists. And when we've gone back and done esophageal studies on them, we find that now they have a new wrap that's too tight. So they have stuff remaining in the esophagus that's actually refluxing and going back up and contributing to the problem. So Nissens aren't always the answer, but you can use these different medicines for these different components. This is the results of Nissen and looking at cough and GRD. And you can just look at what that's showing you is a couple of scales measuring cough and looking at what the outcomes are after surgery. And you can see that there's a persistence in lowering their cough symptoms after Nissen fundoplication. And I think when you're talking about reflux and chronic cough, a Nissen fundoplication is likely to be more effective than just using PPI, because it's dealing with the reflux aid in total, not just trying to suppress the acid component. So these are just some studies, because of time, I'm just going through them, but you have the handout as a reference, which I think shows that they're not necessarily the best randomized, double-blind, or controlled studies, but they do give us some suggestion that, at least in some individuals, the use of Nissen can be helpful. But I think it's important to understand that that's just one of the elements for most of these people in terms of their chronic cough. This is just showing some of the outcomes in terms of resolution and improvement after fundoplication. And again, you can look at that chart that shows some improvement or resolution. You can see that number in the last column, or second to the last column on the right there. This is just, again, a study that looked at the outcomes of cough, and you can look at the 2-year and 5-year in terms of reductions in their coughs, their respiratory and non-respiratory symptoms. So I think that for some individuals, although it may seem to be drastic, there are some people who've had 25, 30 years of cough. Their spouse is more irritated by it than they are when they come in, and they're desperate for us to find some solutions. And so those kind of patients who've had really refractory cough where everything else has been tried, and you have shown evidence that they have some component of reflux, often significant non-acid reflux, that Nissens actually can be effective. But it's all about patient selection. Not everyone with chronic cough and a little bit of reflux that doesn't respond to PPI should be sent for Nissen, but there is a subgroup where it might actually be very helpful. So just briefly going over some of the pharmacologic and non-pharmacologic management for refractory cough. I talked about the use of speech therapy, and so we have a group of speech and language pathologists who go over vocal hygiene measures. They talk about the ways to suppress the cough, diaphragmatic breathing, pursed lip breathing. When someone's going to cough, getting the pursed lips in like this, like that. All these kind of things can help to reduce the amount of trauma and local irritation that happens when people cough, trying to to reduce that cough reflex and that laryngeal hypersensitivity. And then there are other things about the chronic throat clearing that we help them to suppress, relaxation in terms of muscle tension, and talk to them about overuse and various other factors. So this is the respiratory retraining, cough control breathing techniques, and relaxed throat breathing techniques that we use that you have in your handout. There's been ongoing debate about the relative use of these various agents, and some are better in certain type patient populations with chronic cough, and others are better in other situations. So anticholinergics, codeine, morphine, nicotine, mucolytics have all had variable success, and I think you have to individualize it to the patient. There's no one agent that is the first go-to with any group. You need to try and play around with these things. I have not been particularly successful with using such things as amitriptyline and baclofen. They really end up being more last-ditch efforts. But I've had a few patients that have done well with those, but most, it's not particularly effective.
Is there any data that dextromethorphan does anything?
Yeah. There's actually a nice paper by Bolger that summarized what were the effects of different agents, and dextromethorphan was certainly one of the things, certainly with the sort of acute and subacute cough, and then to some extent with chronic cough, that it can be helpful. And the H1 antagonists also can be helpful. Or first generation H2, I should say.
What's the active ingredient in Pessilon that we use?
Benzotenate.
Yeah, does that work?
You know, so in this summary of his paper, it was effective in a small proportion of individuals. It's not, it's again not something that is tried and true and always going to be helpful, but for some people it can be helpful. It's one of the things that can be recommended. And here you can see the list of those things that you were just talking about. Codeine, morphine, dextromethorphan, N-acetylcysteine, uracil, tiotropium, and where they might be helpful. So you have that for your reference. And this is just talking about some of the other agents as well. And as I said, mucolytics, I think there's mixed results. It's debatable about the uses of amitriptyline and baclofen. But for some people who have this neuropathic component to their cough and you're trying to break the cycle, as long as you are dealing with all these other things that I've discussed, the non-acid reflux, proximal reflux, the upper airway cough syndrome issues, and then in addition to using these in speech therapy, you can actually have success. And as far as Botox injections, this is, virtually just anecdotal, just looking at 4 patients who had chronic cough and using Botox injections. I don't find it particularly useful. I've had some of my ENT colleagues do this for some of my patients, and it was not, it certainly was not successful in several of them. So I'm not a big proponent suggesting that this is going to be a game changer. In the future, one of the big areas that there's interest in terms of central modulation and being able to suppress the cough, and I have to say that I think we need to recognize that being able to suppress the cough with central agents is part of breaking the cycle. As far as chronic treatment, I would hope that once we were able to break the cycle, that this increased airway sensitivity would settle down, and that one doesn't need to use either opioids or some of these newer agents long term. But looking at these CRP channel blockers is a big area of interest, not obviously for chronic cough, but even more in chronic pain, but they might have a utility in chronic cough as well. And then there are other agents that are being looked at as well that you can see the list there. So, just to finish off then, first of all, thanks so much for having me here this morning and all your questions. But I do think that chronic cough is the bane of pulmonologists' existence. And I think the challenge is that we need to recognize that for most of these people, by the time they have a cough that's been present for several years or several months, that they've gotten into a vicious cycle. And that if you just try to deal with single issues in treating them, that you're not going to find success. And that you need to spend the time identifying all the contributing factors educate them about the interaction and how they've gotten into this chronic state, and then explain why for the short term you're going to treat them very aggressively to break this cycle. And for many of them, teaching them the speech therapy techniques is very empowering because they've been afraid to go to church, to go to other different activities because their cough has been so disrupted. And teaching them techniques that then allows them to get it under better control can have a significant effect, and also I think is very important in breaking the cycle. Okay, so I think that that's it.
Is there a website where people can look for the technique on suppressing cough? Like a YouTube video that demonstrates how that works?
No, I've been trying to tell my my speech and language pathology colleagues to do that for a long time. Not yet. I guess for now you have to send it. No.
Send it.
That's, I've talked with them about trying to do that because I think that'd be very helpful.
You left out the topic of factitious cough, which a lot of our local pediatricians think is the response that these kids get to start coughing. Do you find that that's a real entity, or do you find if you look hard enough you can find another cause?
I think it's a diagnosis of exclusion. I think that it does exist. There's this kind of group of individuals where there's secondary gain issues and things like that. And so there is factitious coughing. For those people, after you've exhausted all these and shown them that you've given them the benefit of the doubt, that then having them undergo psychological counseling is helpful and important. Yeah.
With VCD, finding a good speech pathologist is difficult. There are only a handful. With this, do you find this is within the realm of common? No, so you have to.
These are, many of these things are the same things that we use for VCD. So having an experienced speech and language pathologist is important.
Is there a chronic cough clinic exclusively for these people at National Jewish? If our worst of our worst, should we send to you?
Well, I end up seeing a good number of the people who have this chronic cough issue. We don't have a chronic cough clinic per se, but we have basically a protocol that most of them will go through in their evaluation. All right. Well, thank you all.
I have one more question. In the folks who cough with an ACE inhibitor, and then the ACE inhibitor is discontinued, but they're still coughing 3 or 4 months later, is that just because that ACE inhibitor selected them as being more likely to cough, or is there some initiation event that persists after the ACE inhibitor stopped? Do you see that kind of?
I'm sorry. Say that one more time.
You see patients in whom that is just a triggering event, but then they cough even when you remove the ACE inhibitor.
Right.
And that.
Right. Well, I think I actually do think to some extent the cough begets the cough, or it starts this vicious cycle that people get in. Often the story is, if you ask people what this started with, it was with a simple viral, upper respiratory, a severe, significant viral upper respiratory tract infection, after which this thing seems to have now carried on for many, many years. So I think some initial inducing event starts this vicious cycle, the cough causing certain reflux, nasopharyngeal reflux, and then they get into this vicious cycle. But in terms of any other kind of changes as related to the ACE inhibitor causing, I'm not aware of.
And it's interesting, we had Mark Riddell here, who's an allergist down in San Diego at the Angioedema Center. He made the point, which I didn't know was true, I didn't believe, that you had ACE-induced angioedema. He's seen people continue to have angioedema for 2 years after stopping the drug, somewhat analogous to the cough continuing after you stop.
Right.
Like we saw a guy yesterday in clinic together who's got atypical angioedema, had been on lisinopril, and is still swelling months later. We don't know what's going on with him, but why these, it doesn't make pharmacologic sense that you should continue.
I think these are the kind of things that they're triggering events that then allow, they stimulate something in the immune system that then persists even well after they've occurred, that still remains unknown and unclear why, but that seems to be what's happening in that situation.
Well, thanks again for coming all this way.
Thank you. My pleasure.
John Walker wrote to me at the very beginning of the Receptors. I showed it to you.
technique now?
Yeah, I think so. That's what I've been doing the last 7 months.
They just I refresh my screen. Refresh my screen regularly. You can see it's still transmitting right now.
Did you know that people were successfully hearing? You were successful.
I was successfully hearing it. So if I can hear it, they can.
But my wife
You'd be able to get my wife and kids. All right, thank you. So we have, next week we have Reflex. In fact, one more time we'll move over here.
Yeah, so
making some progress.
How about that immunology course that hung in the chief? Is that all set? Actually, one of them is usually got the kind of lectures and things. It seems good.
Yeah, I think a lot of
From what she saw for the topics. How is it formatted?
I'm not sure.
yeah, we have
I
to
don't
run up to
know.
Which ended up, remember the numbers of
I think it's 532.
Because you've taken the other
I think
one.
it's 441. Yeah. That one's good, but it's like it's a pretty broad overview. Like, what is the? So this one's supposed to be more geared towards like how.
Oh, okay. So this is really appropriate.
Yeah, I think it's more like but I don't know if registration usually happens.
So will that be?
What's that?
Yeah, usually it's December is the fall quarter. May I help you?
Yeah, you will see.
Yeah, make sure there's different departments just in case we need to check up on it. Make sure we're all totally set.
Yeah, I think it should be okay, but she just said she was sending this check.